Alright, chapter 30 is going to be head and spinal injury. We're going to take a little bit different look into head and spinal injuries too, concentrating on the brain and the skull. So, penetrating neck traumas, life threats, some spine trauma, facial trauma, we'll be going over. So we're going to be looking into the nervous system in this chapter, traumatic brain injury and spinal cord injury. So the nervous system is a complex network of nerve cells that enables all parts of the body to function. This includes the brain, the spinal cord, and the peripheral nervous system. Head trauma is both head injuries and traumatic brain injuries. Can be a traumatic injury to the head that may result in injury to the scalp, head, and skull. Or you can have a traumatic brain injury itself, is injury to the brain caused by an external force. This can be a substantial cause of death and disability. Spinal cord injury, it can be devastating. Also, with a traumatic injury involved also. So the nervous system is divided into the central nervous system and peripheral nervous system. The central nervous system is composed of the brain and the spinal cord, and that's it. The peripheral nervous system conducts sensory and motor impulses to or from the skin, muscles, and other organs to the spinal cord. Voluntary activities are actions we continuously perform. Involuntary activities are actions that are not under conscious control. The scalp is composed of multiple layers. The subcutaneous tissue contains the major vessels supplying the scalp. Lacerations or other compromise to these vessels can result in profuse hemorrhaging. The skull is the cranium and facial bones. The mandible is the only movable facial bone. So that's your bottom jaw. The cranium is occupied by 80% brain tissue, 10% blood supply, and 10% cerebral spinal fluid. The brain connects to the spinal cord through the large opening at the base of the skull called the foramen magnum. There's four major bones that make up the cranium: the occiput, the temples and temporal regions, the parietal regions, the frontal region. The face is composed of 14 bones: the maxilla, the sagittal, and the mandible. The orbit is made out of the frontal bone and two facial bones, and the nose mostly consists of flexible cartilage. The spine consists of 33 vertebrae. The axial skeletal components are stabilized by ligaments, joint capsules, and muscle. The vertebrae are identified according to the location of the cervical, thoracic, lumbar, and sacral region. You also have the coccyx region pictured here too. The vertebral body is made of bone that provides support and stability. The spinal canal encases and protects the spinal cord. So, always remember that you could have a vertebrae that fracture. We'll probably talk about this. But the cord is housed inside of that hollow organ, column right there. Intervertebral discs separate and cushion each vertebrae. Stress on the vertebral column may result in injury to the spinal cord or to the nerve root injury. The peripheral nerve injury is a nerve injury at the peripheral level. Most prominent and most easily palpable spinous process is at the seventh cervical vertebrae at the neck of the injury. Okay, so C7 is usually very palpable when you can see it. The vertebral column can flex and extend substantially. Extreme extension or flexion may damage structural ligaments. Central nervous system. The brain is the center of the consciousness. Its major regions: the cerebrum, diencephalon, the brainstem, and cerebellum. Most metabolically active and perfusion-sensitive organ, and it's totally dependent on the cerebral blood flow. The cerebrum is responsible for higher functions. It's divided into the right and left hemisphere. The cerebral cortex regulates voluntary skeletal movement and level of awareness. The frontal lobe is responsible for voluntary motor action and personality traits. The parietal lobe is controls somatic and involuntary sensory and motor functions for the opposite side of the body, as well as memory and emotions. The occipital lobe is responsible for processing visual information. The speech center is located in the temporal lobe. The cerebellum coordinates body movement, and the brainstem controls virtually all life functions. It consists of the midbrain, the pons, and the medulla. The reticular activating system is responsible for maintenance of consciousness. Centers that control basic but critical functions are located in the lower part of the brainstem. The basal ganglia helps coordinate motor movements and posture. The medulla serves as the conduction pathway for ascending and descending nerve tracts. Spinal cord transmits nerve impulses between the brain and the rest of the body. All right, the meninges is the protective layers that surround and enfold the entire central nervous system. The outermost layer is a strong fibrous wrapping called the dura mater. The dura mater covers the entire brain, folding in to form the tentorium. Meningeal arteries are located between the dura mater and the skull. Second meningeal layer is a delicate, transparent membrane called the acronoid. The third meningeal layer, the pia mater, is a thin, translucent, highly vascular membrane. So, the peripheral nervous system has 31 pairs of spinal nerves, and 12 pairs of cranial nerves. The somatic nervous system regulates or controls voluntary activities. Autonomic nervous system controls the function of many of the body's vital organs, over which the brain has no voluntary control. The cranial nerves pass through openings in the skull and transmit sensations directly to or from the brain. Peripheral nerves conduct sensory impulses from the skin and other organs to the spinal cord. Sensory nerves carry information from the body to the brain via the spinal cord. Motor nerves carry information from the CNS to the muscles. Connecting nerves allow cells on either end to exchange messages, and connecting nerves to the inner spinal cord form a reflex arc. So the connecting nerves in the spinal cord form a reflex arc. If a sensory nerve in the arc detects an irritating stimulus, it will bypass the brain and send a direct message to the motor nerve. The autonomic nervous system is sympathetic nervous system is controlled by the hypothalamus. CSI or above the level T6 may disrupt the flow of sympathetic communication. Parasympathetic nervous system is responsible for conserving energy and maintaining organ function. Disruption of the lower parasympathetic nerves in the sacrum results in the loss of bowel and bladder tone and sexual function. So, pathophysiology, the head injuries, there's two types. There's closed head injuries. These are the most common, associated with blunt trauma usually, and results in skull fractures, focal brain injuries, and diffuse brain injuries. Often complicated by increased intracranial pressure or ICP. So closed head injuries are those that we usually don't see, don't recognize unless we do a very good evaluation. A lot of times you have to look for the blunt injury itself, and it may be something as simple as a contusion, or it may be just a closed fracture. Open head injuries, the dura mater and the cranial contents are penetrated. Gunshot wounds are the most common and may lead to substantial neurological deficit and decreased quality of life. Both of these have the same signs and symptoms. Following an injury, any patient who exhibits one or more of these signs and symptoms should be evaluated promptly in the emergency department. Scalp laceration. Scalp laceration is a small laceration that can quickly lead to a significant blood loss, indicator of a deeper, more serious injury itself. A skull fracture, they can be open or closed. Some signs of deformity, visible cracks in the skull with a scalp laceration. Ecchymosis is under the eyes is raccoon eyes, or ecchymosis behind one ear over the main mastoid process. Now, those are called battle signs. So these are raccoon eyes at the top picture and battle signs in the bottom picture. So be careful to make sure you see these when you go to these pages. Lineal skull fractures is a non-displaced skull fracture. Account for most of the skull fractures. So that's in picture A. A depressed skull fracture results from high energy direct trauma to the head with a blunt object. So the frontal and parietal regions of the skull are the most susceptible. Bony fragments can be driven into the brain, and patients often present with neurologic signs. A basal skull fracture is associated with high energy trauma. Signs include CSF drainage from the ears, raccoon eyes, or battle signs. And that's in picture C. Open skull fractures, brain tissue may be exposed to the environment, and they usually include a very high mortality. Traumatic brain injuries, two broad categories: primary direct injury and secondary indirect injury. Primary brain injury is an injury to the brain and its associated structures that result instantaneously from impact of the head. Secondary brain injury results from the sequelae of the primary brain injury. Usually have cerebral edema, intracranial hemorrhage, increased ICP, and cerebral ischemia and hypoxia. Also may include infections, and hypoxia and hypotension are two most common. Secondary brain injury can occur anywhere from a few minutes to several days following an initial injury. Motor vehicle crash is the most common of a brain injury for people hitting their heads against things inside the car. Injured brain swells initially because of the cerebral vasodilation. Cerebral edema that contributes to further swelling may not develop until several hours following the injury. Low oxygen levels in the blood aggravate cerebral edema. The patient should not be hyperventilated. The only indication for hyperventilation is signs of cerebral herniation. Common response to head injury is vomiting. Appearance of a clear or pink watery CSF from the nose, the ear, or the open scalp would indicate that the door and the skull have been penetrated. Seizures are not uncommon, and the cushion drying is signs produced by the effects of cerebral edema and increased ICP. Intracranial pressure is bleeding inside the skull, which increases the ICP. Bleeding can occur between the skull and the dura mater, beneath the dura mater, but outside the brain, within the brain itself, or into the subarachnoid space. Increased ICP squeezes the brain against the cranium, and a healthy ICP in adults ranges from 5 to 15 millimeters of mercury. Increased ICP also decreases cerebral perfusion pressure and cerebral blood flow. Cerebral perfusion pressure is the pressure of the blood flow to the brain. The minimum CPP required to adequately perfuse the brain is 60 in the adult. Autoregulation responds to decreasing the CPP by increasing MAP, resulting in cerebral vasodilation and increased cerebral blood flow. So if increased ICP is not promptly treated, cerebral herniation may occur. Monitor for signs and symptoms of increased ICP. Early signs and symptoms include vomiting, headache, altered level of consciousness, and seizures. Later signs include the Cushing triad plus a unilaterally unequal and non-reactive pupil, a coma, and posturing. The cortigrate posturing in picture A is when the hands and the feet go towards the cord, into the body itself. And the separate posturing is extension of the arms and the legs and pointing downward in picture B. A focal brain injury is specifically grossly observed brain injury. Cerebral contusion is brain tissue is bruised and damaged in a specific area. It's different than a concussion because it involves physical damage to the brain. Area of the brain most commonly affected is the frontal lobe. Swelling will occur and might result in an increased ICP. Epidural hematoma is accumulation of blood between the skull and the dura mater. It results of the blow to the head that produced a linear fracture of temporal bone, rupturing the middle meningeal artery. The patient loses consciousness immediately following the injury. A subdural hematoma is accumulation of blood beneath the dura mater but outside the brain. The most common intracranial hemorrhage and may or may not be associated with a skull fracture. Results from rupture of veins that bridge the cerebral cortex and dura. The patient experiences fluctuation level of consciousness, focal neurological signs, or slur of speech. And it can be classified as acute, subacute, or chronic. The intracerebral hematoma is bleeding within the brain tissue itself. The subarachnoid hemorrhage is bleeding that occurs in the subarachnoid space. Bloody CSF and signs of meningeal irritation. Common causes of trauma, rupture of an aneurysm, and arteriovenous malformation. Patient presents with sudden severe headache. As bleeding increases, signs and symptoms of increased ICP appear. So, diffuse brain injuries affects the entire brain itself. The cerebral concussions caused by a blow to the head or face if the brain is jarring around in the skull. It's caused by rapid acceleration, deceleration forces, mild traumatic brain injury. Some common features are direct blow to the head or blow to the body with an impulsive force transmitted to the head. Rapid onset of short-lived impairment of neurological function that resolves spontaneously. Neuropathic changes, range of clinical signs and symptoms may or may not involve loss of consciousness. It is impossible to rule out a concussion in the setting of a head injury with transient neurological symptoms. So it is impossible to rule out a concussion in the setting of a head injury with transient neurologic symptoms. So signs of concussion, confusion, and disorientation that may last for several minutes or amnesia. Ask about symptoms of concussion to any patient who has sustained an injury to the head, such as with dizziness, weakness, visual changes, nausea, vomiting, ringing in the ear, slur of speech, inability to focus, lack of coordination, delay in motor functions, inappropriate emotional responses, a temporary headache, and disorientation. So a diffuse axonal injury is a severe brain injury often associated with a poor prognosis. Severity and prognosis depend on the degree of damage. It can be classified as mild, moderate, or severe. That may result in high-speed, rapid acceleration or deceleration forces. Spine can be injured in a variety of ways. Compression injuries can result from a fall, motor vehicle crashes, and other types of trauma. Mechanisms of the injuries, the vertebral fractures can occur with or without associated spinal cord injury. Stable fractures pose less risk to the spinal cord. Unstable injuries involve multiple columns of the spine. Flexion injuries result from forward movement of the head, typically from rapid deceleration or direct blow to the occiput. Patients can also experience lateral bending. In flexion extension, the head moves from front to back and is overstretched on one side while being overcompressed on the opposite side. Rotation and flexion injuries to the C1, C2 areas of the spine are considered unstable. They usually result from high acceleration force. Vertical compression forces are transmitted through the vertebral body, directed either inferiorly through the skull or superiorly through the pelvis or feet. Typically result from direct blow to the crown of the skull. Rapid deceleration from a fall causes fractures without associated cerebral correction, without associated spinal cord injury. Can cause herniation of disc, subsequent compression on spinal cord and nerve roots, and fragmentation into the canal. Hyperextension and distraction. Hyperextension can result in fractures of bone and injury to ligament. Distraction occurs from the rapid hyperextension of the skull, atlas, and axis of the unit. Cervical region is the most vulnerable to distraction forces because it has the least support and protection. Most classic distraction injury is the hangman's fracture. So its lateral forces cause bending and fractures at C1, C2. So spinal cord injuries. Obvious injury, head and neck may indicate injury to the cervical spine area. Injuries to the lower extremities may indicate associated injuries to the lumbar spine and sacrum. Injuries to the cervical area can limit the ability of the diaphragm to function fully and minimize the ability of the chest wall to fully expand. The primary spinal cord injury occurs at the moment of impact. The spinal cord concusses, characterized by a temporary dysfunction that lasts from 24 to 48 hours. Spinal cord contusion is caused by fracture, dislocation, or direct trauma. Secondary spinal cord injury results from the primary spinal cord injury progressing to further deterioration. Effects can be exacerbated by exposing neural elements to further hypoxemia, hypoglycemia, and hypothermia. Minimizing heat loss and maintaining oxygenation and perfusion are key to these injuries. Spinal shock is a temporary local neurologic condition occurring immediately after spinal trauma. It presents with varied degrees of acute spinal injury. Sensory function below the level of the injury will be impaired and usually subsides in hours to weeks depending on the severity of the injury. Neurogenic shock results from temporary loss of autonomic function. Classic case of neurogenic shock is a hypotensive bradycardic patient whose skin is warm, flushed, and dry below the level of the spinal lesion. So your primary survey manually stabilize the cervical spine in a neutral inline position. Focus on identifying and managing life-threatening concerns. And then life-threatening external hemorrhaging must be treated before airway and breathing concerns. Evaluate and monitor level of consciousness. Reevaluate your patient and record observations. In unresponsive patients with any trauma, it should be assumed the patient does have a spinal injury. Clear the mouth and suction if necessary. After opening the airway, be prepared to roll the patient to the side to prevent aspiration. So manually move large debris from the patient's mouth if it is safe to do so. Use suction to clear secretions. Open the airway with jaw thrust maneuver. A nasopharyngeal airway should not be used if a basal skull fracture is suspected or if there is a nasal trauma. So be sure to monitor the airway closely and have a suctioning unit available. Ventilation with a head or spine injury, evaluating breathing, ensure adequate oxygenation and ventilation. Administer 100% O2 via non-rebreather mask if the patient is breathing adequately. Ventilate the patient to maintain an intertidal CO2 greater than 25. Circulation and volume resuscitation, initiate cardiopulmonary resuscitation. Control external bleeding with direct pressure and pressure dressing. Volume resuscitation may be necessary, so assess your radial pulse. Evaluate skin color. And assess for signs and symptoms and treat appropriately. An isolated closed head injury will not cause hypovolemic shock in an adult. If signs of shock are present, carefully assess the patient for occult injury. Decide early whether to complete the secondary assessment on scene or to transport the patient immediately with interventions en route. Prompt transport to a definitive facility is crucial. If available, consider air transport. Maintain patent airway and provide high flow O2. If supine patients, the head should be elevated 30 degrees. And offer psychological support to patients who are alert and aware of the inability to move. In your history is taken, get your chief complaint, obtain a medical history, and identify injury-specific signs and symptoms. OPQRST for background on isolated extremity injuries. Get your sample history, also from your patient, if available. In your secondary assessment, obtain vital signs, modify the physical examination of any patient with a suspected spinal cord injury. In cases of high or immediate risk mechanisms, whenever possible, complete the physical exam with the patient in neutral position. Apply medium stabilization while asking the patient not to move unless specifically asked to do so. Focus your physical examination on the site of injury depending on their chief complaint. If time allows, perform a secondary assessment en route to the ED. Monitor the patient for changes in level of consciousness and estimate the severity of the increase in ICP. Obtain a baseline GCS score. Use simple understood terms when reporting level of consciousness. Expose patient to exam of the spine. DCAT BTLS if there is impairment noted. So a spinal cord injury may also produce pain independent of movement and palpation. Evaluate the chest and abdomen. Auscultation to assess breath sounds may reveal a shortened inspiratory phase. So use your monitoring device. Continually monitor for signs of shock. Examination of the GI system may be unreliable in the presence of a neurological deficit. So in the men, assess the urethral meatus for a prior prism. So look for abnormal posturing and assess glucose levels. In your reassessment, vital signs should be monitored frequently. Be alert for hypotension without other signs of shock. The spinal cord injury is responsible for neurological shock. Also usually produces a flaccid paralysis and complete loss of sensation below the level of the injury. Document the suspected spinal cord injury, noting the area involved, sensation, motor function, and area of weakness. So, head injuries. Treat the patient with a head injury according to the 4 principles. Establish adequate airway, control bleeding to provide adequate circulation to maintain cerebral perfusion. So, get 1/18 large bore IV and monitor your isotonic crystalloid. Shock that develops in a patient with a head injury may be the result of hypovolemia. The only indication for administering glucose to a head injury patient is confirmed hypoglycemia. Correction. If hypotension develops, infuse isotonic crystalloids as needed. So do not allow the patient to become overheated. Scalp lacerations can contribute to hypervolemia in a patient, often indicating deeper, more serious injuries. Control the bleeding by applying direct pressure. Use a dry sterile dressing and fold any avoiders back down onto the skin bed before applying pressure. Do not apply excessive pressure to the open wound. If dressing becomes soaked, remove it and reevaluate the area when pressure is applied. Immobilization of the cervical spine. Stabilize the head and trunk so that potentially fractured bone fragments do not cause further damage. So never force the head into a neutral inline position, and do not move the head any farther if the patient reports muscle spasms of the neck, increased pain with movement, numbness, tingling, and weakness in the arms and legs, and compromised airway or ventilation. Cervical collars can provide preliminary partial support. Should be applied to every patient who has a possible spinal cord injury based on mechanism of injury, history, and signs and symptoms. A rigid cervical collar must be the correct size for the patient. If you do not have the appropriate size cervical collar, you may use a rolled towel around the patient's head. So after stabilization, assess the peripheral motor sensor in all extremities. In any case, maintain manual support until the patient has been fully secured to the backboard. So several types of long backboard immobilization devices that provide full body spinal immobilization are available. So just make sure they're clean, and if they're wood, if they've been contaminated with blood, you might want to switch them out. These are some common short immobilization devices that are best type in the rigid short board. So there are different brands. This is the KED. There's also one that's out there too. The ideal procedure for removing the patient to the ground to a backboard is a 4-person log roll. You may slide the patient onto the backboard using a scoop stretcher. The patient's condition, seeing and available resources will determine the method you choose. Direct the team from a kneeling position into the patient's head to maintain manual inline stabilization. Ensure that the head, torso, and pelvis move as a unit. Just always remember whoever the person is at the head needs to be in command of moving these patients. Use a short backboard with seated patients or a best type spinal extrication device to immobilize cervical and thoracic spine. Secure the short immobilization board to the long board. Only use it in patients who are stable and do not require rapid extrication. Extrications maybe you or the patient is in danger. You need to gain immediate access to the patient, and the patient's injury justify urgent removal. So in these situations, your team should lower the patient directly onto a backboard using the rapid extrication technique. Questions about patients wearing helmets. Is the patient's airway clear? Is the patient's breathing adequate? Can you maintain the airway and assist ventilation if the helmet remains in place? Can the face guard be easily removed to allow access to the airway without removing the helmet? And how well does the helmet fit? Can the patient move within the helmet? Can the spine be immobilized in a neutral position with the helmet on? If the helmet does fit well, the patient's head is from moving and should be left on. This is provided that there is no impeding airway and breathing problems. It does not interfere with assessment and treatment of the airway and ventilation problems, and you can properly immobilize the spine. Removing it will further injure the patient. Remove a helmet if it is a full face mask helmet. If making assessing and managing airway problems difficult, and removal of a face guard to improve airway access is not possible. If it prevents proper immobilization of the spine, it allows excessive head movement, and the patient is in cardiac arrest. So sports helmets are typically open in the front and may or may not include an attached face mask. The mask can be removed by simply removing the cut and the straps that hold it to the helmet. And most of the time, your sports trainers on the sidelines have the tools to remove those helmets. Motorcycle helmets often have a shield covering the face. If a shield cannot be removed, the helmet must be removed. Before removing a helmet is at least a two-person job. Depends on the actual type of helmet. One AEMT provides constant inline support as the other moves. You and your partner should not move at the same time, and consult with medical direction before removing the helmet. If you do need to remove a helmet if airway is accessible, correction, you do not need to move it. If the airway is accessible, head is smooth inside, and the helmet can be secured to a mobilization device. So, alternate method allows a helmet to be removed with application of less force, slightly more time consuming. So, remove the chin strap and remove the face mask. Pop the jaw pads out of place using a tone depressor. Press your fingers on the side of the helmet. Do a movement of the helmet to gently rock it back and forth off the top of the head. The person at the side of the patient controls the head by holding the jaw with one hand and the occiput with the other. Insert padding behind the occiput to prevent neck extension. Shoulder pads are in place. Appropriate padding must be applied behind the head to prevent hyperextension. The person at the patient's chest is responsible for making sure that the head and the neck do not move during removal. Small children may require additional padding to maintain the neutral inline position. Smaller airways and proportionally larger heads needed to maintain the airway and place blanket rolls behind the child and the sides of the adult-sized bed. Non-traumatic spinal conditions. Back pain is one of the most common physical ailments. Upright posture places a substantial amount of weight on the lumbar spine. Most people are susceptible to injury or degenerative diseases. Spinal tumors can cause pain and debilitation. Most cases of low back pain are idiopathic and may pay special attention to the patient's medication. So pain may result from the strain or sprain of a paravertebral muscles and support ligament structures without substantial injury to nerve elements. Tumors in the spine from a variety of metastatic carcinoma can cause pathologic spine fractures. Degenerative disc disease is common. Disc herniation may be caused by some degree of trauma in the patients with pre-existing conditions. And the most common areas are the L4, L5. L5 is 1, but can occur as high as the C5, C6, and C6, C7. So the pre-hospital measure of low back pain is absence of trauma as primary and palliative. And that's the end of this chapter. Activated. Consider the need for paramedic backup. Decision of whether to immobilize a patient depends on your local protocols and not purely mechanism of injury. High-risk mechanisms of injury strongly suggest possibility of spinal injury indicate the full spinal immobilization should be considered. Some examples are high velocity crash greater than 40 miles per hour with severe vehicle damage, unrestrained occupant of a moderate to high-speed motor vehicle crash, vehicular damage with compartmental intrusion 12 inches into the patient's sitting space, fall of an adult from a height greater than 20 feet, and fall of a child from a height greater than 10 feet.